critical care in pregnancy, background, um, what are the leading causes of ICU admission during pregnancy? One is hypertensive disorder, the other one is OB hemorrhage. Other causes: sepsis, trauma, respiratory condition, cardiovascular events, diabetes, ketoacidosis, GI issues such as pancreatitis, appendicitis, and bowel obstruction, overdose/poisoning, neurologic disease. 5 out of 1,000 deliveries are admitted to the ICU. 3% death rate for ICU admission in OB patients. And then let's talk about sepsis. So sepsis is defined as infection with organ dysfunction. Septic shock is defined with needing vasopressors to maintain mean arterial pressure greater than 65 millimeter mercury. Serum lactate level is also greater than 2 millimoles per liter. When should we assess for organ failure? So systemic blood pressure is less than 100 millimeter mercury. Respiratory rate is 22 plus. Altered mental status. If 2 out of the 3 is positive, this warrants further evaluation. Early antibiotics is key. Each hour of delay is associated with increased mortality. Acute respiratory distress syndrome. Non-specific response of the lungs to a variety of insults, such as diffuse inflammation, increased fluid level in the lung, loss of aerated lung units. Low tidal volume ventilation, decreased mortality in non-pregnant patients. Factors contributing to decisions to move to the ICU. 1, 2, 3, 4, 5, 6. Clinically unstable, such as hypotension and hypoxemia. High risk of deterioration, such as increasing work of breathing, needing mechanical ventilation. Arterial blood gas, serum lactate should be monitored. It is largely dependent on availabilities of resources and staff capability in postpartum and laboring units. Most OB patients only need level 2 care, which is close monitoring and simple interventions. They rarely need level 3 care, which is major organ support. Hospital transports, continuous cardiac rhythm and pulse ox monitoring. Venous access must be established and lines secured. Left uterine displacement during transport. If high probability for intubation and ventilation, this should be established before the transport. Fetal monitoring or TOCO monitor during transport is individualized due to intervention might not be possible during the transport. In house transports, the team must have cardiac monitor with defibrillator, airway management equipment, oxygen, basic resuscitation medication, mechanical ventilation, PA, CO2 should be greater than 40 millimeter mercury. Oh, PaCO2 of greater than 40 millimeter mercury is concerning for OB patients, but normal value for non-pregnant patient. Normal pH of 7.4. Normal pH of a non-pregnant woman is 7.4. Pregnant pH first trimester 7.45, and the third trimester 7.43. Table 2, let's take a look at table 2. Let's see, hemodynamic monitoring. Subclavian or internal jugular vein is preferable to femoral access. Arterial cannulation indicated when instantaneous blood pressure monitoring is needed. Radial artery is the most commonly accessed. Carotid artery and femoral site are avoided. Resuscitative hysterectomy in the setting of cardiopulmonary arrest. If resuscitative measures are unsuccessful, hysterectomy is recommended for maternal benefit if the uterine size is at or above umbilicus. This may help return of spontaneous circulation by emptying the uterus and alleviate the aortal cavo compression, increase cardiac output, and improve efficacy of cardiopulmonary resuscitation. 45% of in these resuscitative hysterectomies, 45% died, 45% survived without obvious sequelae, and 10% survived with significant morbidity. Fetal survival is 60% without sequela, 20% survive with significant morbidity. Hysterectomy should be undertaken after 5 minutes of arrest with without a return of spontaneous circulation. 50% injury-free survival rate even at 25% at 25 minutes. So let's take a look at table 2, the mechanical ventilation. So table 2. So the pH in the non-pregnant woman is 7.4, first trimester 7.5, third trimester 7.43, 7.45, and 7.43. PA oxygen normal 93, first trimester 105, third trimester 106. PaCO2 normal 37, first trimester 28, 29, third trimester about the same, 26 to 30, so much lower. So higher PaO2 and lower PaCO2. Serum bicarb normal 28, first trimester is 18, third trimester is 17. So increased PaO2, decreased PaCO2, and decreased bicarb to compensate. Or is it respiratory alkalosis? So that's that.